Hi, my name is Jessica Montanaro. These are my capstone practice slides, and I'm going to discuss an ARDS overview. What do you know about ARDS? ARDS is an acute respiratory distress syndrome. It's an acute inflammatory lung injury and is always the result of another severe underlying disease. ARDS, otherwise known as ARDS, which is used interchangeably, is not a primary diagnosis. Rather, it is secondary to some initial triggering event. There are many causes for ARDS. Some are direct and some are indirect, and sometimes there can be a mix of both. Direct causes of ARDS would be primary lung injuries. Those are injuries directly to the lung itself. So, pneumonia, aspiration of stomach contents, perhaps long term mechanical ventilation, and even blunt force trauma to the chest are some examples of primary lung injuries that are direct triggering agents for the cascade of ARDS events. Indirect injuries would be injuries that occur outside of the lung in more of a systemic setting, such as sepsis. Sepsis happens to be the major indirect cause of ARDS. Pancreatitis, burns, and multiple blood transfusions are also greatly associated as having triggering the ARDS cascade. What I want you to take away, if you don't know, is that ARDS carries with it an extremely high mortality rate of about 40% according to literature. The mean age is about 51 years of age. So, of 100 people, 40% of them will die when diagnosed with ARDS. ARDS does not discriminate against between the young rather and the old. You can be young with one comorbidity or old with several comorbidities, and you still face a very poor prognosis once you are diagnosed with ARDS. It's a very emotional and difficult um, disease process that nurses, critical care nurses, and clinicians find very difficult to take care of. There are very few, even to this day, ARDS specific managements that have been shown to improve the mortality of ARDS. There are some very clear defining characteristics. ARDS is acute, and it's an acute onset of profound hypoxemia. You can have saturation levels in the 60s and 70s despite being on high ventilator settings and high oxygen requirements. We call it acute because ARDS can occur within hours to 7 days of some identifiable triggering injury, like the ones I just mentioned. Classically, you will have bilateral opacities detected both and or on chest x-ray or CAT scan. It's very classic. And then we have this respiratory failure. This patient is just in complete respiratory failure, but it's not explained by a cardiac component or fluid overload. So they look like they're in pulmonary edema, but with very normal cardiac function. Most of you probably, if you're in the critical care world, would be familiar with the PF ratio, and that is one of the defining characteristics of ARDS. ARDS with a PF ratio between 200 to 300 is considered mild, 100 to 200 is considered to be moderate disease, and then less than 100 is considered to be very severe, and usually you have the worst prognosis there. What you're looking at here is a very classic chest x-ray picture of an ARDS patient. This is not one of our patients. This patient was taken off the cited radiological website, and this particular patient happened to have been involved in a near drowning event. So that would be a direct injury to the lung. And you can see these very dense consolidations, which are classic to ARDS, and they are at the lower bases of the lungs, and that's pretty typical. And you can also see that despite all these pulmonary effusions in this almost whiteout picture, we still do have a very normal cardiac silhouette. So there's not cardiomegaly or any identifiable cardiac component. And you can still see other anatomical thoracic structures like a normal diaphragmatic outline, all which are very classic to ARDS. And that's my quick overview. Thank you so much.